Today, I'm speaking with somebody who has devoted years of study into looking at the rights and the wrongs of medicine. Her Instagram page says that she's an author, lecturer, and ethical mentor. She is also something of a founder, an initiator, because over the years she has founded or co-founded 5 institutions that interpret and speak ethics into everyday life. She has been policy advisor in medical ethics on the Archbishops Council of the Church of England and been a member of the BMA's Medical Ethics Committee. A theology graduate from Oxford University and one-time research fellow at the Centre of Medical Law and Ethics at King's College London. My guest's interests in medical ethics is more than academic. It is also personal. A few years ago, in response to myeloma, which is a bone marrow cancer, she underwent radical and transformative stem cell transplant. So here to speak with me today is Dr. Claire Gilbert. Claire, welcome. It's so lovely to have you with us today.
Thank you, Nigel. It's a delight to be here and a privilege.
Thank you. Let's start right at the ground level then about medicine. It's all built on trust, isn't it? We trust what the doctor says. We trust that he or she knows what they're talking about and that what they're going to give us is the right cure for whatever condition we have. Doctors, in turn, they trust the drug companies that the pills and the potions, they're all going to be safe and they're all going to be, as Mary Poppins might say, efficacious. So why have we grown up to trust doctors and the whole field of medicine? I'm
not sure we have.
Oh.
When I was deep in the world of medical ethics in the 1990s, we academics thought that patient autonomy trumped medical paternalism, as we called it slightly pejoratively. That is to say, patients were ceasing simply to obey doctors' orders and starting to think for themselves, and it was essential that consent was sought, which is how a patient's autonomy could be exercised. And it is true that increasingly we don't just take our doctor's word for it, we Google, Dr. Google, as doctors really know, patients will do and will question. However, I'm bound to say that my own personal experience changed my thinking here. So consent, this is the theory, the legal truth. Consent to be valid has to be given by a competent person, has to be not coerced, and needs to be based on adequate information, which is fine and dandy. When I was diagnosed with cancer in 2019, I was so overwhelmed by the diagnosis that I barely heard what followed. In order to make a valid response to the question, not just do you want this treatment, but will you enter a clinical trial and receive your treatment that way? I wasn't making sense of the information I was being given. It was a flood. I wasn't competent because my mind was in a whirl, and I felt coerced because not by any person, but by the cancer. That is to say, I had cancer. I had to do something about it. How could I say no? So that made me think, not sure about the doctrine of consent here. And it made me think, I absolutely must trust my doctors, my clinical team. And what's more, Nigel, that trust has a therapeutic element as well. Because if we don't trust our clinical team, then we won't receive our treatment in the way I believe we need to receive it, which is willingly. Yeah. It's an act of faith. It's a strong act of faith. And I made a decision, given that the position I was in, that I would do that. I would trust the clinical team.
Was there any sort of ethical argument you had with yourself about whether this was right choice for you or not?
I'm bound to say that this particular treatment, stem cell transplant for people with myeloma, the blood cancer that I had, is a long established treatment. And it doesn't really raise ethical issues because the stem cells came from me. So after a series of chemotherapy, 4 months of chemotherapy, they harvested my stem cells. I mean, it's extraordinary technology. And then they gave me a drug, it's called melphalan, which is it has mustard gas based on what was used in the Second World War, which killed off all my bone marrow. And then they transplanted back into me my own stem cells. It was absolutely horrible. Being brought right to the brink of death, and then over a period of time, a couple of weeks, coming back to life. Most extraordinary experience. I wrote about it in the book, which is a series of letters, Miles to Go Before I Sleep. But some people receive stem cells from donors, and some people receive treatment based on embryonic stem cells, and the ethical issues go up with each of those steps. I think, to be honest, the stem cells from donor, not embryonic stem cells, but stem cells from donor, the real issue is the kindness of possibly strangers or family, because having had bone marrow biopsies, you drill into the bone, which you would have to do to retrieve the stem cells for treating this disease, is another unutterably horrible procedure, the most painful I've ever known in my life. So I would be undyingly grateful to anyone who went through that on my behalf. It's such an altruistic act. Embryonic stem cells is another stage again, on which we can talk about now, if you would like.
Yes, let's go there. It was back in 1990 the Parliament passed the Human Fertilisation and Embryology Act, and that allowed research into what they called therapeutic use of human stem cells. The most powerful form of stem cell is found in 3 to 5 day old embryos, also known as blastocysts. Typically, those are left over from infertility treatment, IVF treatments. How ethical is it to use embryos? Some might even term them as unborn children in this way.
So the question is, when does life begin? And there was a conversation between a Catholic priest, an Anglican vicar, and a Jewish rabbi about this. And the Catholic priest said, life begins at conception. The Anglican vicar said, no, life begins with the first independently taken breath after birth. And the Jewish rabbi said, you're both wrong. Life begins when the kids leave home. I looked into this.
I can see your years of ethical training have really informed this conversation.
I looked into this in great detail because when it was the 2004 embryonic stem cell research bill that was coming through Parliament, and when I was advising the Church of England, so the bishops were in the House of Lords taking part in this debate. Now, there's it's not a moment of conception. There's the process of conception when the egg is fertilized by the sperm. That takes a little while, and then the embryos, it becomes a blastocyst, as you say, travels up the fallopian tube, and on its journey, the journey of those embryos, 70% fail at that point. They are washed out. The remaining 30, this is over a population. In general, 70% of fertilized embryos on their way to the womb fail to reach there. Once it has implanted in the womb, it's only at that point that it, as it were, knows how many people it is, because it might divide and become what we know as identical twins. So, and what's more, those extraordinary stem cells, which grow into every bit of our bodies, also grow into the placenta and umbilicus. So right from the start, we are both ourselves and our environment. I find that quite extraordinary and a really important ecological principle, as it happens. But when in that stage does life begin? And when I was advising the Church of England, I put the case for life beginning at conception and the case for life beginning at implantation. I put those two sets of arguments absolutely fully. I wasn't trying to win an argument. I said I presented them. But I'm bound to say in my own case, I am persuaded by the thought that only when a seed is in the field, and as we've heard Jesus talk about, and dies, and then is able to grow, only when implantation happens can we say that there is life emerging.
And advances, my observation is advances in laboratories and medical facilities often arrive, or possible advances, the potential for medical advances often arrive in the lab before there is a law to regulate its use. How? I know who decides, Parliament decides, but how? What ethical basis are laws passed? And we're going to come on in a while in this conversation to the forthcoming assisted dying bill. Where's the ethical, moral basis for deciding that actually, yes, Claire, life does begin at conception, or yes, Claire, life does begin at implantation? How do people get? Where do they get that? How do they decide?
So we have to recognize that humans are always going to discover things, then the law will hurry to catch up. And you hope for, first of all, you hope for ethical people doing the research. So the orientation of the research is towards the good, towards service, towards loving service, towards alleviating suffering, and not for profit or indeed power or gain. And it was one of the things working in the ethics of medical research on humans, particularly, that you had this awful situation where doctors would say, I want to find this thing which will cure cancer, let's say. And the zeal to get to that answer means that you don't notice the means by which you get there. You don't notice the cost of getting there. So first of all, we really hope and pray for researchers who are oriented towards the good, or who are surrounded by people who will help them be oriented towards the good and remind them of their humanity and their morality. When it comes to, so legislation is a clumsy tool. We'll come to that when we talk about assisted dying, and it can only do so much. And you do want to avoid legislation that simply says no or simply says yes, of course. But nuance in law is so hard, particularly statute law. I mean, the one I was closest, the process I was closest to was on the embryo research bill. And I ended up being so grateful to the former Bishop of Oxford, Richard Harries, for, as it were, rolling up his sleeves and getting involved, because we ended up with legislation that was permissive in the sense that it allowed embryo research, but with really careful regulatory frameworks around it. So it happens, but we don't allow ourselves to stop taking the human embryo morally seriously. But it's fallible. We are all just humans trying to regulate this.
And not only is the law subject to human input, shall we say, the law can be fallible, but also, as you've already explained, even a faith perspective, people of different Christians, for example, will have different views on when life begins, and I'm sure, I know there are different views in the Christian community about the whys and the wherefores of helping somebody to die. So it's all imperfect, isn't it?
Yes, it is. I mean, I like that. Okay, I wouldn't like. I think absolutism in any form coming out of a human mouth is worrying. We need to stay curious, open, prayerful, aware of our own fallibility, always asking for guidance, always asking, and never thinking we've arrived there. And that counts too for when we start discussing these things, that we don't pick up megaphones and start shouting at each other. We listen, because as I found again and again and again when I was directly advising the Church of England and working with colleagues in other denominations when I was doing that in medical ethics, people hold their views generally for very principled, very thought out reasons, prayerful reasons. So we do well to listen to each other and learn from each other.
Now, on Friday this week, it cannot escape many people's attentions that the House of Commons is due to debate the issue of assisted dying for terminally ill people. There's already been a first reading in the House of Lords of a similar piece of legislation earlier in the year. Now, what we haven't heard so much in recent days and coverage is actually the proposed provisions of the bill. So I would just like to outline the process, if I may, before I bring Claire in and ask for her expert opinion. Now, under the legislation, the proposal is that a person who is terminally ill signs a declaration saying that they would like to be helped to die, and that declaration is witnessed. And that person then is assessed by a doctor who has to determine that they are terminally ill, that they have the mental capacity to make their own decision, that they're making the decision voluntarily without anybody forcing them, that they are over 18, that they've lived in England or Wales for at least the last 12 months. And most importantly, the doctor has to assess whether the patient is making a clear, settled, and informed wish to end their own life. Then there is a 7-day period of reflection. Then a second doctor makes a similar assessment. And then, if both doctors are convinced that this is ready to go forward, it goes to the High Court, and a High Court judge has to determine whether the legal requirements of the bill would be an act will have been met. There is then a further period of reflection, up to 14 days, or if the person seems to be or is assessed to be less than 1 month from death, then there is 48 hours reflection. Then the patient has to make a second written declaration. And then the lead doctor has to make a second written statement. And it is only then that the doctor can give the patient a suitable substance for them to take themselves, and the doctor would stay with the patient while that process was happening. In the event of death, the doctor then would sign a death certificate and say that the patient died within the terms of the then act. That's the process. Now, Dr. Claire, to what extent do you think legalizing assisted dying in this way would be a mark of a civilized society?
You know, Christians, of all people, should not be afraid of death. I pray, in my case, that when death approaches, and I've had my brush with death with the cancer diagnosis, and indeed every 3 months I'm checked to see if it's come back. It's an incurable condition, not although treatable. I pray that I will experience what to me is a sacred journey. I will willingly allow, as it were, life to go. I will willingly walk towards my maker. And I won't, because the body instinctively try to hang on to life. And I pray, and I would ask any clinician who has care of me, any loved one who has care of me, not to prolong my life in any way, shape, or form. I would also pray that I would be not in pain, because pain is so destructive of everything. And I would hope that a medical profession would endeavour in every way to offer that kind of end-of-life care. And in many cases, I believe it does, but not always. And we have all, I've no doubt, heard stories of really horrific situations that people have faced and their loved ones have faced. I'm still not convinced that legislation will answer that, though. I think it's a clumsy tool for something that is so sacred, so delicate, so important. And just as it's of course we need medical support, but medicalizing and indeed setting strong legal, close-in legal laws around birth as around death is to lose the deep, deep humanity and I would say spirituality of it. And I'd have to go back to this question of consent. So I told you how difficult consent was. I wasn't, in the strict legal sense, I wasn't really consenting to the treatment. And I know of older people who would, without a shadow of a doubt, consent to something like this in order to avoid being a burden, but they would do it in order to avoid being a burden. And is that really consent? However, caveat that the 6-month rule does
Sorry, can I just clarify? Yes, it's 6 months. This is a provision. This would be a legal provision for people who are terminally ill and who have up to 6 months to live.
So the thing that older people really worry about is spending years in nursing homes, gaga, spending their children's inheritance. Well, this law isn't going to deal with that. So we won't have that problem of older people consenting to something because they don't want to be a burden. But it is such a communal thing, a death. It's all about the people around you as well as you, just as illness is, as I've really learned. The loved ones, oh my word, it's as much about them as it is about the one going through it.
So you personally, if this were to become law and to become available as an avenue to leave this earth, you cannot see yourself wanting to avail yourself of this possibility.
I don't know. I think it's unlikely, but because what I pray for is something more prayerful than that, less controlling than that, less medicalized than that. But don't hold me to it, Nigel. I mean, we can't say never. We don't know what we will be when we are in particular situations. And I wouldn't judge another.
No, absolutely. It's Claire, you're speaking very personally, and I thank you so much, because that's it's very vulnerable of you. But yet it is within our vulnerability that we can reach out and touch others. I know so well. As an academic, then, looking at this piece of legislation, rather than speaking for somebody who's come very close to death and who is human and doesn't know, and we can all sympathise, I'm sure, with that. As an academic, what's the ethics of helping somebody to die when they are in pain and when they want to have some control and when they want to have some dignity and when they have a clear, settled and informed wish, as the bill puts it, to end their life?
Well, it's hard to refuse if all those conditions are in place and your intention is to alleviate suffering rather than to kill. And we have this so-called doctrine of double effect. Your intention is to help, to serve, to love, to be compassionate. If that means a life is ended.
We see this. Do we see? Well, I say we do. I'll ask you. Do we see this double? I can't say. I was going to say double jeopardy, but it's not. This double effect. We already see it, do we not, within the medical profession with terminally ill patients, when
Yes.
when clinicians decide, actually, it's time now to withdraw treatment.
Yes.
We won't be giving you the drugs anymore. We won't be, so the heart, the motivation is to help, but ultimately it is likely to be shortening life.
Yes, not only withdraw, but also withhold. So somebody may have, I don't know, pneumonia or something, and you say, well, it would be unfair to give them antibiotics. They're dying anyway, and this might be the merciful thing that carries them off. Well, what causes the death? The pneumonia, the decision not to treat it, or the whole, as you say, withholding of treatment. This does already happen. And but the trouble is there's such a fear of litigation now. So doctors may act, and families feel guilty if everything isn't done. I heard pediatricians talk about this in relation to dying children, that they sometimes found themselves continuing treatment, because the parents were so distraught. They so needed to know that everything that could be done had been done. So there's a society-wide lesson here about death, which will come to all of us. We need to hear that. We're too controlling, and this is almost the mirror of it. This legislation.
So we all have, certainly this generation, this post-war generation, and generations, you know, whatever label, trendy label they're given, you know, we all expect to have happy lives, long fulfilled lives, shiny lives, no problem lives, and it's the case, isn't it, that this society, unlike say the Victorians, where many children, for example, died, were lost in childbirth, you know, we are not used to handling death up close and personal. We want to sanitize it. We don't want to think about it. We don't want to think even about our end time or what is going to happen to us after death.
A friend of mine who's disabled pointed something out that really struck me. He said the reason people are nervous around or often push away disabled people is that it reminds them of what will come to them as they get older and become frail themselves. It will come to all of us. Yes, we're lying to ourselves if we think suffering won't come to us, death won't come to us.
Can you see within this proposed legislation? Well, as I say, it's being debated in the House of Commons on Friday. That actually there is an angle about the family, because when family members gather or are summoned to a hospital, nobody knows when the loved one is going to die. Not even the clinicians can tell you. And I've been in so many pastoral situations over the years where, you know, how long have they got? Oh, nature takes its course, you know, or when God calls, or whatever phrase you want. There is so much unclarity about when life will end in particular cases. But isn't one of the unintended consequences of this piece of proposed legislation the fact that actually the family will not have to suffer the not knowing when mum, dad, or whomever is going to go, because there will be a very clear timetable?
Yes, that may be a good thing, or it may not be a good thing. And you have the worry that the family will be distraught that this decision has been made, and feel they've let their loved one down in some way, that they feel they need to take matters into their own hands. I mean, we all know the situation where people wait until everyone's left the room and then they die, as if they need to be let go of. It's one of the great services to somebody who's dying, is that you do let go of them, that they don't feel they have to hang on for your sake. And maybe this will help that. I don't know.
Many medicines, as we know, just don't come to us out of the packet or out of the bottle. They have been in development for absolutely years, and many come through clinical trials. But even before that, they are tested on animals. How ethical is it? How comfortable are you with our medicines first having been treated and trialed on animals, or even on people?
I'm less comfortable about animals as time goes on. Actually, we are understanding better and better that animals' physiology doesn't necessarily tell us that much about human physiology. So animal research isn't the answer to everything. However, I do recognise, having looked and worked alongside pharma in respect of the development of drugs, I do understand how important, for the moment anyway, the toxicology studies are for safety. And at the moment, there isn't a better way that we know than some animal research. So my plea and hope then is that, and I should say, incidentally, I eat meat from time to time, I wear leather, I don't regard it as inappropriate for humans to use animals instrumentally. What I do say matters ethically is that they don't suffer. And to put it in the horrible, cynical way, you can say a happy pig is a tasty pig. Ethically sourced meat, animals used in research who don't suffer, seems to me to be critically important.
Now, you mentioned there of your involvement with pharmaceutical industry. Healthcare in the UK, as we know, and we thank the NHS and God for, is largely, quote, free at the point of use. We depend in this country upon readily available, affordable, and effective drugs. COVID was a great example where the pharmaceutical companies developed vaccines that literally saved millions of us. In the 1960s, though, many pregnant women suffered from nausea and were prescribed thalidomide. This resulted in thousands of babies being born with severe birth defects. Now, with COVID, Big Pharma was the savior. Right? Very clever scientists came up very quickly, rolled out the drugs, and now getting our annual COVID jab is as commonplace as getting a flu jab. With the thalidomide, though, pharma was not the savior, the pharma was the devil. So what are the ethical considerations for Big Pharma?
You have to do your research properly and ask the right questions. So the thalidomide drug, it just didn't occur to the pharmaceutical industry that this might be an outcome. It wasn't looked at. And if you think about it, how would you construct a research project to discover that this was the outcome of this drug? But well, I mean, I guess it would be animal research. Horrible, really horrible to know that this would be an outcome. And I'm bound to say there are some people who think the vaccines have awful side effects and don't think pharma is the savior. Yeah. I'm not one of them, but as far as the vaccines are concerned, I mean, pharma, it's to do with how you design the research. It points up the importance of research, including on humans, and why I was so happy to take part in a clinical trial myself as part of my cancer treatment, because I am enjoying treatments that others have taken part in as research subjects before, that have built on their willingness to be human guinea pigs, you might say. So all of that really does need to happen. I mean, pharma is in it for the money, of course, but my word, they have saved our lives as well, and they invest literally hundreds of millions of dollars in research and development in order to produce these drugs, and somebody has to make that investment.
One of the increasing developments medically and technologically that is invading all of our lives is that of artificial intelligence, or AI. Robotic surgery, for example, is sometimes used in some theatres throughout the world for particular medical procedures. Now, at a time when we are all in the UK, well, I say all, many of us in the UK are having to wait longer to see a GP in person, would RoboDoc be a good idea? And what are the would you see are the ethical implications of increased automation within medicine?
I think there are huge benefits of it, huge benefits, the sorts of things that AI or machine learning can be trained to see that doctors tired after a long day, repetitive tasks, for example, that a machine would see that a doctor might fail to see being human. But there are things which, in my opinion, machines can never replace. And these are to do with the thing that happens in the encounter between two humans. And I had my own experience of this with my own GP in his surgery with him, when he said, I think we better follow up this anomaly, this kidney anomaly. And that's what led to the cancer diagnosis. And that was something that happened between us face to face as two human beings. That's not going to happen with that. Well, actually, I suppose that specifically maybe an AI would say yes, but it might not. But there was something about that encounter I will never forget. I regard it as life-saving. And it's a care, and love and service. We can't replace that human-to-human meeting. But loads and loads of things that robotics, AI can offer within medicine. It just needs to be handled so carefully, not be used to replace the human element, but to enhance the human element, to allow people to humans to spend more time being human rather than just robotically, I don't know, checking scans or whatever.
Yeah, I remember interviewing earlier in one of our earlier seasons of Questions of Our Times. I interviewed somebody who was very into health, the whole subject. She had a very big healing ministry, and we were talking about the human touch and how we need, as social beings ourselves, we need human interaction and human contact. And she said, one of the most healing things is when you ask somebody how they are and you're prepared to listen to the answer.
Yes, brilliant, brilliant. And it wouldn't work with a machine.
It doesn't feel like it. When you go to the ATM and it chews up your card, it doesn't, you might shout at it, but it doesn't answer, does it? It's not very sympathetic.
No.
Claire, our question today is, how ethical is medicine? We've had a big view of a wide landscape. Before we go to our listeners' questions, what is your answer? How ethical is medicine?
Very.
Oh, right. Okay, that's it. Right. You heard it here, folks. Very ethical. Thank you. Claire, here we go then. This is the quick fire round. Somebody asks, Simon says, you spoke about the need to trust our doctors. Do you think that trust would be damaged if doctors are allowed to end patients' lives? I think this is within the context of the assisted dying bill. Do you think trust would be damaged if doctors are allowed to end patients' lives, and does it worry you?
It might well be. Yes, it might well be. Even with all those conditions as you describe them that are in the bill, sorry, not yet an act, people might not believe it. They didn't when the Liverpool care pathway was invented, which was meant to be an acknowledgement that we all move into palliative care at some point and stop being acute care. You got families saying, "Oh, my daddy was put on the Liverpool. That means they want to kill him." So I'm afraid it may well do, yes.
Because under the stipulation of the bill, it very clearly states that actually the doctor would give the substance to the patient. The patient would administer. The doctor would be there in attendance and witness either the death or if the patient at the very last minute decides not to take the dosage.
Yes, but this is nuance, and we know how less and less and less is nuance given a place in public discussion, and I'm afraid it would be lost. Yeah. I'm so sorry about that, but I'm afraid it would be lost.
So the doctor would still be blamed, even though they didn't actually administer themselves.
I'm afraid in some quarters, in some arguments, on some social media, yes. Yeah.
I'm glad you mentioned social media, because the next question is touching on that. And this is about vaccines. Conspiracy theories, false information about vaccines, the likes of COVID and AIDS seem to be growing in political power, especially in the United States. How do you think governments should respond?
Well, you'd hope they'd respond with nuance and understanding. But unfortunately, this is the cost of democracy, because democracy says we elect our leaders. Our leaders need to win in order to be able to govern, which means they need to seek power. And if your voting base, are calling out for you to respond to this kind of conspiracy narrative, well, you might do it in order to get elected, and it's terrifying.
Another one now, just in from a listener. Again, this is relating to assisted dying. The Book of Job. I always like it when somebody quotes the Book of Job, because that means they are serious and they're dealing with the nitty-gritty of life. The Book of Job says that, quote, "The Lord gives and the Lord takes away." Does that mean we can't try to choose the time of our own death, as the assisted dying bill seeks to do?
Do you know, I would say the Lord gives and the Lord takes away. Whatever we humans do or try to do to gainsay God's plan frankly, I don't think this is going to stop God any more than any other attempt is. So in a way, I'm not worried about that. It's more, what's the wise thing for humans? What's the wise thing for a flourishing, trusting society?
Again, on an assisted dying, this seems to be, well, we know, we're not surprised by this. This is what people want to know about. Does Dr. Claire think, is there any ethical difference between taking a terminally ill family pet to the vet for the last time and helping a beloved relative end their own suffering?
It's such a good question. We often say this. I wouldn't let my dog suffer the way my nan suffered. I suppose we're humans, and we try to be guided as Christians by our faith, and we do regard human life as sacred and not to be taken lightly. So we would say there is a difference, but I can really understand why some might say it's worse for humans than it is for animals. And maybe there's a certain distaste as well, but then it's a good distaste, because we don't want to end up as people who take each other's lives lightly.
Indeed. You're quite right. Well, we're flooding in now. We've got 5 minutes. This is even quick, Brad. Right. What are your biggest worries? Asks Jeff in Oxford. What are your biggest worries about the future of medicine, and what are your biggest hopes?
Oh my Lord, my biggest worries are that we so medicalize our lives that we lose the human element, that we so seek to control our lives that we lose the human element, that we start to believe that we really can determine every moment of our lives, that medicine promises that being happy and healthy and all those nonsensical things all our lives with no interruption whatsoever, and all our loved ones. But it's never going to happen, actually. But the medicine, in a way, focuses on that. My hopes, was it hopes?
Yes, it was hopes. What's your biggest hope for the future of medicine?
That it will continue to seek to serve compassionately and lovingly the needs of humans, and not pander to our silliness.
Okay, right, moving on. Jess in Swindon. Again, quick fire round. Are you concerned at all about data privacy in medicine? It worries me that all my medical problems are on a central database.
Well, look, this is a difficult one. So there's the individual confidentiality matter, but then the NHS, because of being a centralized system, has a phenomenal amount of data which can be so valuable epidemiologically for future treatments. And a bit like the toss-up between privacy and security, there's a toss-up between privacy and health. And I'm bound, I suppose, because I'm quite communitarian, I'm bound to think, I'd like my data to be used. So I suppose I just hope that the use will be wise and respectful of people's privacy or confidentiality.
Thank you. How can churches, asks somebody, one of our listeners, how can churches do better at welcoming and integrating disabled people into their communities?
Oh, so much better. You know, I'm writing a story at the moment, story of Jesus, and pondering on his healing ministry, and at the same time being very aware of disabled people and the importance of really understanding, actually, that disabled people show us what it is to be human. Of course, no disabled person would say no to the disability being taken away from them. But I've made Jesus disabled, or a bit disabled, and indicated, because I think disabled people can talk, and I know they can talk about this, with acceptance, the disability becomes a superpower. Churches should deeply understand that disability brings a sense of humanity, and it's to be respected and loved, and couldn't be loved, shouldn't be. There should be no question that there's front and center of our ministry, not on the periphery, bang in the middle. They should have pride of place.
Last question. When Jesus was on earth, he healed people rather than give medicine. Do you think medicine has replaced the need for that kind of healing? Does Jesus still heal? Does Jesus still heal in answer to prayer today? You have 20 seconds.
I believe so. But I also believe that medicine plays its part, and we would be foolish as humans not to use our wit, intelligence, and compassion to administer as wisely as we can what we have available to us.
Claire, thank you so much for your time, your honesty, your sharing, and your insights today. My guest today has been Dr. Claire Gilbert. This conversation actually concludes the current season of Questions of Our Times, brought to you by the Christian Evidence Society. To catch up on any of this or the 3 previous seasons of our conversations, or to learn more about the wide-ranging ministry of the Christian Evidence Society, please visit christianevidence.org or premier.plus. Until we meet again, the Lord bless you and keep you and make his face shine upon you. Thank you for listening.